our instruction codes is basically depends on expander device. This is a new experimental study. Now it is established and published in a Indian Journal of Ophthalmology. So you first know what is expander, how it acts, and and the clinical application of this expander device. Our first speaker is Osik Mukhopadhyay. He is a senior resident RIO Kolkata, Orbit Oculoplasty. His topic is basic principle of novel tissue expander, applied physics, and a mathematical calculation for the expander device. Over to Osik.
Good morning, everyone. Thank you, sir, for the kind introduction. So I am going to be talking on the basic principle of this novel tissue expander as designed by our chief instructor, Professor Mondal. It's applied physics and mathematical calculation. A large eyelid defect is always a challenge to the oculoplastic surgeon. During eyelid reconstruction, there is often a need for the additional tissue to be recruited to cover large defects, and for a full thickness eyelid defect, we can reconstruct the posterior lamella by an ipsilateral tarsoconjunctival flap, a free tarsal graft from the contralateral lid, a hard palate graft, a nasal or ear cartilage graft, or dona sclera. And the anterior lamella, it is obtained by the local myocutaneous flaps or from free skin. If this defect is large and a large amount of tissue is needed, the technique of soft tissue expansion can be used where there is definite shortage of local tissue, and the temporary expansion of the tissue helps to cover the defective area. Now a little bit about the history of tissue expansion. Marx Malcolm in 1985 studied the physiological accommodation of tissues to 5-day expansion in a porcine flap model. Garber et al. Reconstructed both upper and lower lids using eyelid tissue expander in a patient of Liburn in 1987. Jill Foster in 1998 described the rapid intraoperative tissue expansion to increase the available tissue area for defect closure, and this was when first the Foley's catheter was used as an expander. And as late as 2015, Margulis Alexander described about the tissue expander, how to insert it underneath the forehead skin and expand serially. So here we introduce the 10 French silicone Foley's catheter to be used as expander device, as it is commercially available and readily can be used in hospital settings. There is a slight modification in our technique, as there we cause temporary expansion of the skin, muscle, and soft tissue complex, and this expanded tissue is further used in rotational or advancement flaps. Now the role of tissue expansion, how does it work? The explanation for the tissue expansion working is that the physical force when it is applied causes a multidimensional expansion, and this generates a stimulus for local angiogenesis and neovascularization. The strain induced responses are mediated by several growth factors such as the endothelial growth factor, platelet derived growth factor, and TGF beta, and there is also alteration of the cell membrane proteins. This causes increased vascularity of the skin muscle flap, and this may help in the long-term flap survival and less chances of flap necrosis. And due to rapid vascularization of the host bed, in case of free graft, the acceptance is also very high. Now we were thinking about what type of expander should we use. Commercially available expanders can be custom made, custom built, however they are very expensive. So we decided about the shape of the implant to be chosen. Initially we thought about rectangular or crescentic expanders, as they yield the greatest surface area as compared to round expanders. The expander base should be more than 2.5 times the size of the defect, and the implant volumes usually range from 10 to 400 ml. A remote injection port is necessary, as it permits easy localization and has a lower risk for inadvertent puncture. This type of principle has been used in post mastectomy breast reconstruction to generate local tissue for a permanent silicone prosthesis. So all of these features we found to be available for our requirement from the Foley's catheter. So initially we selected the location for the expander placement. It should be in proximity to the defect and with the area of the most available skin to recruit, such as the forehead, the temporalis and the preauricular regions. We thought about the lid proper, but I'll get into why this cannot be used there. Initially we placed the incisions of the expander placement along the hairline, the brow or in a pre-existing incision line. Then a large pocket was dissected between the skin and the superficial temporal fascia in the temporalis region and between the periosteum and the gallia in the front of the frontalis muscle in the forehead. Gradually, the tissue expander was expanded gradually and it was filled to the point where the overlying skin became taut and the skin color was not deranged. The patient discomfort was assessed and over the period of 2 to 6 weeks, the expander was gradually inflated 1 ml in each sitting. After 6 weeks, the expander was deflated and removed through the previous incision and the second stage of the surgery was performed. But however, in the first 2 cases, due to this prolonged period of expansion, we noticed that there was necrosis of the tip of the advancement flap and as a result hyperbaric oxygen therapy was necessary. However, the scarring process led to a medial eyelid retraction. So we began to think what is the cause of this tissue necrosis, because this same procedure has been used in several parts of the body. Then we realized that there are 2 types of changes that are occurring when a tissue is placed under stress. This is known as creep and stress relaxation. The creep is the increase in the length of the skin compared to its original length when it is placed under constant stress. Initially, upon mechanical expansion, there is collagen restructuring, there is disruption of the elastic fibers, there is fluid displacement and tissue migration, and this leads to the biological creep as mediated by the growth factors such as angiogenesis, fibroblast proliferation and epidermal tissue proliferation. For the initial 1 to 2 weeks, this is the mechanism that occurs, but if the tissue is placed under constant stress, at a point in time, there is decrease in the stress and the tissue becomes rigid and non-elastic and it is permanently deformed. This is known as stress relaxation. So we began to understand that if we place a tissue for a rotational or advancement flap under a long period of stress, then that tissue will be immobile, will be rigid and cannot be modulated as necessary. So we began to decrease the period of expansion. First we came to 1 week expansion. From the initial 2 to 6 weeks we came to 1 week, and then gradually right now we are performing for 3 days. Also we modified our technique such that the tissue expansion is the expander is being placed under the skin and the muscle just above the periosteum. For this we thought of as I said, we thought of different types of expanders, but for the requirement of our requirement, we found that the 10 or 14 French silicone Foley's catheter is ideal because it is readily available in the hospital, it is inert, non-toxic, and it may be removed as soon as possible if any sign of complications arises. The volume of expansion in the balloon of a silicone Foley's catheter causes an ellipsoidal area of volume of expansion of the skin, and as a result this is ideal as compared to a round expander where their unnecessary skin and the muscle may be expanded. So we'll go into a short animation about how to plan for such an expander placement in the temporal region. For a lower lid defect, if we plan a mustardy rotational flap or a Tengel rotational flap, suppose this is the proposed incision. Now on the proposed incision, from the highest point of the incision, we'll draw a tangent. We draw a tangent line and the short axis of the ellipsoidal area needs to be placed along this axis. Now we will see where are the positions we can place the balloon of the silicone Foley's catheter. As we all know, the silicone Foley's catheter expands in all 3 directions. As a result, we can place it, we have to place it over an underlying bony surface. This can be the zygomaticotemporal region, this can be the supraorbital or the infraorbital region. But in case of eyelid expansion, if we place the expander within the eyelid tissue, since there is no underlying support, this will cause pressure upon the globe and on the orbital contents. So this type of expander cannot be placed within the eyelid tissue. Now, in comparison to the traditional expanders used in post mastectomy breast reconstruction, those type of expanders expand in 2 dimensions, and as a result this type of expander cannot be used in case of our study. Now we'll see 2 short videos on the use of the expander, how to put it. This is a patient of a lower lid tumor, most likely malignancy, with more than 50% involvement. Now we'll place the proposed incision, as I already said, over the zygomaticotemporal region. From the highest point, we'll draw our ellipsoidal area. We have to, as the balloon of the silicone Foley's catheter is placed 1 centimeter down from the tip, we have to plan for insertion up to 1 centimeter beyond the area of expansion. Now please note that after incision of the skin muscle up to the periosteum, the scissors which we are using for the dissection, they are not being opened up. See here, the scissors, they are not, no type of blunt dissection we are not carrying out, only single plane, single axis dissection. Then the silicone Foley's catheter is being introduced 1 centimeter beyond the area of expansion, and the balloon of the catheter is expanded, and this will cause the expansion and the recruitment of the local tissue. We have to keep in mind not to injure the superficial temporal artery, as this may cause torrential bleeding. The rest of the catheter is placed over the auricle and fixed beyond the post-auricular region. After 3 days, the balloon is deflated, and at this point, we'll use this technique for reconstructive procedures. This is the similar placement of an ellipsoidal expander in the infraorbital region to be used for Cutler-Beard procedure. Similarly, the ellipsoidal area is marked. The long axis and the short axis are measured, and then we'll introduce the blunt tipped scissors up to 1 centimeter beyond the area to be expanded. The balloon of the catheter is then introduced under the muscle over the periosteum, and this is kept in place for 3 days. Now we'll see from our next presentation that there is definitive proof of the increased vascularity and tissue changes. We have measured also in case of supra or infraorbital placement, we have to measure the intraocular pressure periodically. After 3 days, the expander is deflated, and this tissue is further used for reconstructive procedures. Here are some clinical photographs of how to place the expander in the zygomaticotemporal area. And as we can see, reconstruction with this procedure has excellent cosmetic benefits, as the incision length is getting reduced. Now, how to calculate the area of the ellipsoidal region? This is calculated by pi into the semi-major axis and the semi-minor axis. That is half of the long axis and half of the short axis. From our study, the mean elliptical area to be expanded by the Foley's catheter in the upper lid was 4250 square millimeter, and the lower lid was 4251 square millimeter. Thus, we can see that this is extremely predictable. The predictable tissue expansion occurs. The mean incision length for the lower lid modified Tengel flap was 62.27 millimeter, whereas without expander in our previous studies we have found that for the similar type of defect this has been 99.83 millimeter. Thus, the reduction of the incision length for the lower lid Tengel flap was 62.37%, and for the upper lid, I will not go into the details, the reduction was 73.28% reduction in incision length. Thus, we can see that this happened to be the initial incision, proposed incision, and after tissue expansion, the required incision was only this much. This entire tissue has not been touched. There is no injury to the facial nerve or to the superficial temporal artery, and there is a combined reduction of 63% in the length of the incision. Now, as I said, that the silicone Foley's catheter should be applied on the periocular region or under the lateral orbital rim against a bony surface, and this application should be done not to damage any major vessels or nerves such as the superficial temporal artery. However, this expander requires one hard bony surface which cannot be used over the lid, and we have observed that the rapid expansion from 6 weeks, if we convert it into a rapid expansion for 3 days, this causes more angiogenesis and increased vascularity of the flap that helps in good reconstruction and promotes wound healing. Thus, the take-home message is that the silicone Foley's catheter can be used and should be used probably as a novel tissue expander for modified Tengel rotational flaps or for advancement flaps to repair upper and lower lid defects. In this procedure, lesser amount of tissue needs to be dissected and the incision length is significantly reduced with respect to conventional Tengen flap, and the use of tissue expander allows repair of even up to 100% lower lid defects and cosmetically causes much less scarring with respect to conventional surgical procedures. And the most important part, that early visual rehabilitation is possible. For a conventional cutler beard, we'd have to wait up to 6 weeks. The patient would be unable to see if the patient is a one-eyed patient, that is the only seeing eye. Imagine if that happened to some of our relatives, that the patient is not able to see in the only seeing eye for up to 6 weeks. And so early visual, we are not closing the eye, and even from if we had expanded for 1 week, 2 weeks, the patient hospitalization would have increased. So we have reduced it down to 3 days. And the catheter's balloon inflation property is used as the expanded device in this study. It is a safe material, widely available, and is cost effective. Therefore, to conclude, 10 or 14 French as per requirement of silicone Foley's catheter, urinary catheter, is an excellent tissue expander for developing countries where access to other expensive options is limited. Thank you for your kind attention.
Hello. Hello. The next speaker is Dr. Shankar Subra Chaudhary. His topic is a Doppler flowmetry study to evaluate the flap vascularity and wound healing of the tissue expander. You must understand the anatomy and the basic principle. Now you see what happens to the expanded tissue in vascularity. Over to Shankar Subra.
Thank you, sir. I am here going to discuss on the Doppler flowmetry study to evaluate the flap vascularity and the wound healing with the use of this novel tissue expander. Now the aim of the presentation is to evaluate the blood flow dynamics used in the tissue flaps using the Doppler flowmetry study, which is a non-invasive technique. Here we investigate the Doppler flowmetry measurements after tissue expansion utilizing a novel silicone catheter balloon and propose a standardized treating clinical protocols. And the goal of our study is to offer the evidence-based guidelines for clinical integration of the Doppler flowmetry in the patients in the future use. Now, previously, a study by Coadio et al. Showed the use of laser Doppler flowmetry, but it showed concern about the use of the probe, the use of the splint, and the duration of the measurement, and also depends upon the skill of the practitioner. Sarah Dell et al. Showed that the tissue stretch not only promotes upregulation activation, but enhances underlying angiogenic mechanisms that are responsive or unresponsive. Now, vascular growth-related blood flow is detected by the laser Doppler flowmetry, but this study is very expensive. Another study by Sao et al. Showed that a physical examination combined with acoustic Doppler sonography remains the cornerstone of post-operative sleep flap monitoring. Now, Yano et al. Showed that the color Doppler sonometry is a simple, extremely useful and a reliable method for assessing the vascular status. And another study by Tabelli et al. Showed that the Doppler method helps to correlate the course of the wound healing events and help in studying the wound repair dynamics and the tissue perfusion. Now, in our study, which is a hospital-based prospective observational study, in which the expansion was used in 10 patients, for the 6 patients in the zygomaticotemporal area, and for 4 patients in the infraorbital areas. For the 3 days, the expansion using a 10 to 14 French urinary catheter was used, and after 3 days, the catheter was removed. And by the Doppler flowmetry, we evaluated the peak systolic velocity, the end diastolic velocity, and the different indices. We included all the malignant tumors, including the upper or the lower lid, any lead having a congenital malformation requiring a reconstructive surgery, and in cases of scar revision surgery due to catastrophic injuries. But we excluded any malignancy that has a lymph node involvement, disseminated metastasis, or an infiltration in the cornea. The first, there was a technique validation was used using the 10-0 Foley's catheter, and the precise measurement was taken. And for that, the protocol that we set was the first, on the day 1, there was a baseline Doppler flowmetry parameters was evaluated before insertion of the 10-0 Foley's urinary catheter, and the established for blood flow velocity, the blood flow volume, and the resistance indices. Here we can see that initially before placing there is very low amount of blood flow, and on the red dot, and the total number of blood vessels is very few. And then the tissue was inserted, and with controlled expansion over 3 days, the 10-0 Foley's catheter was placed in the area proposed by the incision and the ellipsoidal zone. And after 3 days, the balloon was deflated, it was removed, and again repeat Doppler flowmetry measurements were taken, and the data was compared with the baseline measurements. And here you can see that after the tissue expander release, the number of blood vessels also increased, the blood flow increased, and the blood flow velocity is also increased. Here you can see the live demonstrations before the expansion and after the deflation of the balloon. Here you can see there is hardly any blood vessels, and the blood flow is very much minimal. But after the removal of the 10-0 Foley's catheter after 3 days, here you can see the recruitment of the blood vessels has increased tremendously, and the blood flow velocity is also increased. Here is another patient where we can also see the pre-insertion of the blood Foley's catheter and post deflation of the balloon catheter. And here you can also see that the number of blood vessels has tremendously increased, which was not present before the insertion of the Foley's catheter. So the parameters that we explored were the peak systolic velocity, the end diastolic velocity, and the number of vessels. And here you can see that the peak systolic velocity increased from 6.98 to 10.90 centimeter per second. The end diastolic velocity also increased from 2.36 to 3.68 centimeter per second. The number of recruitment of blood vessels have severely increased from 2.30 to 6.30 per centimeter of area. The resistive indexes were reduced from 1.28 to 1.17, and the resistive index also reduced from 0.66 to 0.64. The vessel diameter of the vessels present also increased from 0.06 to 0.10, and the blood flow indices also increased from 0.14 to 0.04. So the Doppler from the other traditional methods that were explored previously has a more quantitative, predictive, and the advantageous data, and the previous data were mainly dependent on the clinical examination. And the outcomes of the balloon catheter were also surgically correlated. There were increased amount of blood flap survival. The complications rates severely decreased from the other conventional methods, and the wound healing has been improved over a period of 3 days, which required many weeks in the previous studies. So the benefits of the Doppler evaluation has a is present in all the three stages. That is the pre-expansion stage, the during the expansion stage, and the post-deflation stage. And the benefits are helpful in both the tissue recruitment, the increased vascularity, more in faster healing, and shorter incision is required. So we improved the guidelines for a future use in our studies. So we can integrate this Doppler flowmetry in each of our patients for a clinical evaluation, and we are going to integrate these our studies for a standardized treatment protocols. And in future, if there is also development in a Doppler flowmetry, we are also going to incorporate that indices in our study. But we know that this whole of the study needs a long-term follow-up, which is lacking, and we have to integrate other additional parameters that are also present in the Doppler flowmetry. So the key takeaways are there is more faster healing, there is increased outcome of the flap vascularity has shown faster healing, and the number of vascularity increased. As a result, the patient can go home early, which is required 2 weeks to 6 weeks in the previous all the studies. Thank you.
Excellent speech by Shankar Shubro. You must understand the vascularity is increased. Now, the clinical application of the expander device. Dr. Raka Chatterjee will be talk on the scar revision surgery in case of a balloon expander device, how it acts. You know the applied physics and mathematics calculation, and then application and the Doppler flowmetry for the vascularity. Now you see the clinical application, how it works. Over to Raka. Raka Chatterjee is one of the consultant of Susud Eye Hospital. She works on the orbitochloplasty and reconstructive surgery. He is in our team.
Thank you, sir, for including me in this instruction course. Now, I shall be talking on the use of tissue expander in scar revision surgery and skin graft. Now, a scar is a body's natural way of healing and replacing lost or damaged skin. The scar is usually composed of fibrous tissue. Now, there are different types of scar. Clinically, it's an atrophic, it can be hypertrophic, it can be flat, or it can be a keloid. The collagen synthesized initially is random and constitute of bulky fibers, which eventually remodels along the line of tension. Eventually, these randomly distributed collagen fibers are replaced with stronger and more organized collagen, representing a smooth, flat, and pale scar. Now, the large eyelid defects are caused by trauma, can be following coloboma, for following tumor excision. Now, we have to reconstruct the eyelid, and subsequent to the eyelid reconstruction, if there is formation of scar, we have to manage them. Now, there are different methods, can be conservative, can be surgical. Conservatively, we manage with scar massaging. We can use scar softeners, creams, silicone dressings or gels, compression garments. Steroid injection is one of them, and among others include radiotherapy, laser therapy, cryotherapy, etc. There are different types of surgeries. For linear scars, Z plus T, and for diffuse scar, the basic principle is scar excision followed by filling the defect by different flaps and skin grafts. Now, it is always our preference that we should do a minimum intervention to the patient. We should have a minimum incision, we should have a minimum amount of skin grafting. So, we should go ahead, we should plan for a better tissue mobilization. We need more tissue. Now, if we have some way to have expanded tissue, then we can mobilize them better and the subsequent residual defects, if at all we needed to cover with a skin graft, the amount of skin graft to be harvested will be definitely small. Now, one of the methods to recruit more skin in the lead reconstruction is the graded tissue expansion. Already my previous speakers have nicely demonstrated and described the basic principles and vascularities of this method, and this is a new method performed by Dr. Mondal and already published in Indian Journal of Ophthalmology. The tissues adjacent to the skin defect is expanded here with an expander where the reservoir is inflated with the fluid. After a certain period of time, the expander is deflated with the achievement of the desired expansion. Here, the number 10 French Foley's catheter is being used, and it's a cheaper item than the available normal tissue expander devices used in plastic surgery. In this method, tissue mobilization becomes very easy to close a defect. The stress relaxation property of the skin is the basis as already described, and 10 to 14 French silicone inflatable balloon urinary catheter is used for this myocutaneous tissue expansion adjacent to the scar. Here I will show a short video where the tissue is expanded adjacent to the scar for a period of 3 days. After that, the main surgery has been done, where the scar excision, tissue mobilization, followed by skin grafting to have the final cosmetic and functional outcome. The area to be expanded is measured and the Foley's catheter is introduced. This is the inflatable balloon in the Foley's catheter. From 1 centimeter away, the incisions are made for insertion of this catheter. And it's a myocutaneous part of the skin that is inflated and expanded. Ideally, 3 days are kept. Now, after removal of the Foley's catheter, we go for the definitive scar management. The excision of the scar tissue, as is shown. Tissue is mobilized and remaining small defect is closed with a skin graft. Now this is another video, few clippings. The scarred area, comparing both the eyelids. We measured the area. Insertion of the tissue expander. After removal, the same thing, the scar excision and harvesting of the skin graft. This is definitely the small area of skin was harvested, and after tissue mobilization, the graft was placed. Thank you very much for your kind attention.
This is the clinical application of scar revision surgery. Our next speaker is Dr. Purban Ganguly. Is clinical application of expander device. A larger incision is converted into shorter incision in a rotational flap. So after scar revision, then we can go over to the flap surgery. It's all after the tissue recruitment. Purban Ganguly is now the assistant professor of Regional Institute of Ophthalmology, Medical College, Calcutta. Over to Purban.
Thank you, sir. Thank you for giving me this opportunity. Hello. So we'll be like, most of it has been discussed, so I'll be very brief. So, so, in case of tensile rotational flap, when we are using for tensile rotational flap for upper eyelid reconstruction as well as lower eyelid reconstruction, we have to keep certain things in mind. The goals of the eyelid reconstruction is that the eyelid should have the anatomic integrity, the physiological function of the shutter, as well as like a barrier, which is a lower eyelid, and the vision and the cosmetic outcome is also very important. Now, reconstruction of any eyelid, whether it's upper or lower eyelid, will require three-layered reconstruction. There is the outer myocutaneous part, the inner layer of the conjunctiva or the mucosa, and the semi-rigid skeleton that is interposed between them in case of upper eyelid, that is a tarsal replacement. Now, here, as we are discussing that we are using a 10 French silicone Foley's catheter, which is available in the market. Now, we have to realize, as Dr. Chatterjee has been telling earlier, that less tissue mobilization means less surgical induced scar, more the less chance of post-operative morbidity of the patient, less hospital stay, less chance of infection, and less better cosmetic outcome. Now, the conventional tissue expanders which are available are nothing less than 120 to 150 US dollars, whereas silicone catheter comes in the price of nothing more than 200 INR. So if we can do with the silicone catheter the same or maybe better outcome than the conventional tissue expanders, then why not? So Ostrich has already discussed the principles of tissue expansion. So the aim of this study was to evaluate the efficacy of 10 French silicone Foley's catheter as a skin and soft tissue expander. As I have said, the cost and the safety of the silicone Foley's catheter as a tissue expander and the surgical outcome of the surgery is also compared. Now, in the study design, in this prospective non-comparative interventional study of 30 patients over 18 months, we had included all upper and lower eyelid malignant tumors up to a created defect of 40 to 70% after removal of the tumor. And distant metastasis, local lymph node mets have been excluded from the study. Now, here I would like to emphasize that if you see that the functional outcome of the study is very good. The mean palpebral fissure height 4.8 plus minus 6 standard deviation, and after 6 months it is becoming 9.6, and LPS action is also improving. Now, if you see the expander with expander, the mean incision length is coming down to 70, as with the proposed without expander the tissue length. It is almost 1/3 to 1/4 reduction of the incision length, which will have a better cosmetic look, rehabilitation faster, and the blink reflex will be preserved in all cases. So this is a surgical procedure of the old style. Here we will see that in a case of a lower eyelid defect, which is more than 50% of the lower eyelid has to be incised because of the huge shape of the tumor. Medial masses are always difficult to manage. So here we will see that after excision of the tumor, we are having a technical glitch. So after the glitch, hello. glitches happen in all great shows. So let us hope. It is not coming over there. So as I was telling that after medial masses are always difficult to manage because of the location, and here you can see it is a huge mass, and such masses are not very uncommon in our country. So here we had to perform a master D cheek rotation flap. With the incision, you see the incision will go down beyond the tragus of the ear, and it will cover almost the cheek, entire of the length of the cheek, and we have to do a very fine subcutaneous dissection so that the myocutaneous flap can be interposed to cover up the medial tissue defect in the lower lid that has been created due to removal of the tumor mass. Now you see there are a lot of problems of these long rotational flaps because there is facial nerve, there are arteries covering up the cheek, and that might cause post-operative longer length of the stay of the patient, as well as intraoperative and post-operative complications. Here you see we have to ligate the vessels, the bleeding vessels. We have to ensure that there is no problem in the vascularity of such. Whenever we are dealing with a long flap, so there will always be a problem with the vascularity. Now there will be periosteal fixation so that there is no slippage of such a large flap, because such a larger the flap, more will be the chance of slipping back into its primary position and wound dehiscence. So we have to be very careful in dealing with such large flaps. So after mobilization, you see such a long incision length. This long incision length is very important. Now after this, we'll have a very short video of another procedure where there is a same mass in the lateral position, and we will use 10 French or 14 French silicone catheter as a tissue expander, and a lot less tissue will be. This is the proposed incision length that is being first drawn. You see it is almost 11 millimeter in shape. And as Ostrich has already described, that due to the ellipsoid shape of the balloon of the catheter, there is less chance of periosteal necrosis, and there is more chance of superficial myocutaneous part being deflated. So here you can see that the area we want to be deflated, we have to go at least 1 to 2 millimeter above the area. The tip of the catheter should be reach there, and there will be slow dilatation of the catheter. Now the problem is that how long shall we keep the catheter in place? As Ostrich has described, that if we keep it more, the tissue will become rigid. If we keep it very less amount of time, then the tissue will not be expanded adequately, and more tissue mobilization will be required. Now in this study, we have kept it for 7 days. Even with 7 days, the result is not bad. So if we see that after mobilization of the flap, this is the condition of the patient. So you see the proposed length was very big, but the ultimate length was nothing more than 7 millimeter. So this, as we have, we are yet to find. We are coming to the last part of our instruction course, where we will see that what is the particular outcome of how long should we keep this expander to get the practically the best outcome in the tissue expansion. So let us now introduce our chief instructor, Professor Dr. Sholil Kumar Mondol, who will give us an insight into the latest work as using 10 French silicon catheter as an expander device. Professor Mondol did his MD in ophthalmology from AIMS New Delhi. He has more than 22 acclaimed publications in peer-reviewed national and international journal. He is a reviewer of Indian Journal of Ophthalmology. He has participated in a lot of national and international seminars. He has been a web trainer in orbit and oculoplasty in cloud meeting for CyberSight, and he has received American Medal of Association Recognition Award, and he has presented multiple papers in international conferences as prestigious as ARVO since June 2015. So he's Chief of Orbit and Oculoplasty in AIO Kolkata. Let us hear from the horse's mouth regarding the latest in tissue expansion. Thank you.
Hello. Now, the novel tissue expander, the inflatable balloon with 10 or 14 French catheter, is a wonder in ophthalmology. Now, we have seen the flap surgery, we have seen the skin grafting, and the scar revision surgery. You must know the basic principle of an applied physics, how this expander device is worked here. Now, I will show. It's not moving. It's not moving. Let's discussion over the video. This is a expander device we applied here. So this patient is operated here. The expansion of the tissue for 7 days. The question is why there is 7 days? 7 days is too much. You can't do a temporary disfigurement of the face. That is, patient is not satisfied. Due to malignancy, the patient can allow, but logically it should not be. So we change our plan from 7 days to 3 days expansion of the tissue. Now, in 7 days, the tissue relaxation is done. But previously we do 15 days where the tissue expand is not done. It become a fixed swelling. So now you see, after 7 days expansion, automatically tissue is dissected there. And we do rotational flap. Now we change our concept from 7 days to 3 days. Why 3 days? Because in short duration, tissue expansion is here, disfigurement is less, long hospital stay, and increased expenditure. Now this is a lower eyelid tumor. It is basically a 100% defect. Now we applied expander device to recruit a newer tissue. Again, you see, this is the baseline Doppler flowmetry. এই হচ্ছে মুশকিল। Now this is a area where this is dissected. Now our study is 3 days expansion. Again, the baseline Doppler flowmetry done to evaluate the vascularity. Baseline vascularity to compare why this is quick healing of the tissue. Previously, none of the scientists developed that, described that why the quick, what is the utility of the expansion of the tissue. If the tissue is expanded, there's a lots of things happen. One is the vascularity is increased, that is proof by Doppler flowmetry. And after that, this is after deflation of the balloon, the increased vascularity is there. Then you are sure that this flap must be developed, quick healing, and a good scar is possible, and the cosmetic appearance is much more better. So we do this patient have a 100% lid involvement. Massage cheek rotational is the rule. Now we avoid a massage cheek rotational because most of the facial nerve is cut, the patient may leads to a lid lag. The may causes corneal exposure. So avoid this massage the cheek rotational flap. We get a shorter tangential flap by the help of expander device. We recruit a newer tissue, newer, much healing, and the vascularity increase. We are sure that the healing must be good. This is the proposed initial length, where, and the actual initial length, the length of reduction is 70% almost, 70.1 millimeter with standard deviation. This is a good clinical application of the expander device, a good scar. We avoid a massage cheek rotational flap and finish a 100% effect with a tangential, short tangential. So comes to a conclusion that 10 French silicone catheter is much more useful, cost effective, readily available, and this Novel ability not only used in India, it is also in US. So we believe the expanded tissue in a, you can do a larger defect with a short incision length. So this is published in Indian Journal of Ophthalmology, is one of the best publication in the orbit and oculoplasty this year. Now, again, our experimental study is early division. It is possible. Cutler beard is naturally open the second stage up to 6 to 8 weeks. But in our study, we do a cutler beard within a 2 week. It is possible? Yes, it is possible, the use of an expander device. How it works? Early revision of modified cutler beard procedure using novel tissue expander for breech flap formation and novel filamentous knitted polyester fabric for tarsal plate replacement. Newer experimental surgery, clinical application of novel expander and the novel filamentous knitted polyester fabric for tarsal replacement. Previously, we published in Indian Journal of Ophthalmology for a silicone plate for the replacement of the tarsal plate. Now we switch over to a polyester fabric, the newer material. Aims object to evaluate the surgical outcome, safety, efficacy, to assess the surgical, anatomical, cosmetic outcome of early division of modified cutler beard procedure with 2 weeks for early division rehabilitation of the patient in lid tumors, to appraise the cost effective of 10 French 14 silicone catheter. So results of Doppler flowmetry, this MRD1 minus 1.2883 to 4.6 millimeter, pre-op PFH value 1.66 to 11.25, and the LPI action 1.50 to 14. That means a good cosmetic outcome. And the Doppler study, peak systolic velocity is 6.98 to 10.90 centimeter per second, and diastolic velocity is 2.36 to 3.68 centimeter per second, and the pulsatile index. Pulsatile index is the peak systolic velocity plus end diastolic velocity divided by mean velocity is the ratio of a pulsatile index. And resistive index is 0.66 to 0.1. How will you calculate? Peak systolic velocity minus end diastolic velocity divided by mean velocity is the indices of resistive index. That will help how much the blood flow in the local tissue, how much the velocity of the blood flow increases, and also the number of blood vessels which is increased in that area. In a baseline Doppler flowmetry, after deflation, again the Doppler flowmetry to detect the number of vessels. Previously, none of the scientists, they detect. We have a hypothesis that Doppler flowmetry can increase the vascularity. Some of the authors, some of the scientists, they develop expansion of the tissue may causes increased vascularity, but nobody proof. We are now scientifically, statistically proof that all the vascularity is increased by the data source. Diameter of the blood vessels is also increases, blood flow is increases, that we are sure this type of surgery, chances of failure is less. And most important is early separation of anterior posterior lamella. Now comes to a surgical procedure. This is an upper eyelid tumor. Our plan is to do a early rehabilitation. Cutler beard procedure, basically second stage done after 6 to 8 weeks. This is the conventional study. Now we are the first time try to use, is it possible the rehabilitation within 2 weeks? Doppler flowmetry baseline first to done to detect the vascularity of that area. Then Again, the same procedure, single axis dissection, not too much dissection. When the balloon is expanded, automatically the soft tissue is dissected. Doesn't require the dissection of a blade of a scissor. This is the balloon which is uniquely separate the tissue, cannot block the artery or vessel or vascular compromise the local area. This is the 10 French or 14 French balloon of the catheter used for the expansion of the tissues. Plastic surgeon basically use the expansion of the skin, but we are the first time expanded the skin muscle complex. So this is success with the skin muscle complex to recruit extra tissue. IOP is measured very careful. When you expand the tissue in a infraorbital region, any moment the force transmitted to the eyeball that may cause increased IOP. And if you've not detected, you are a blunder that may lead to optic atrophy and glaucomatous optic atrophy. Again, the Doppler flowmetry done to increase the vascularity, we are sure. Now we goes over to the mainstream. Now the usual procedure, the Cutler beard procedure, what is a rectangular defect is created. If it is a tumor in the upper lid, we goes a malignant tumor. The rule is 4 millimeter all around with a frozen section biopsy to rule out prevent the recurrence of the disease. This is a stage 1 Cutler beard procedure, removal of the tissue, wide excision with the frozen section biopsy to prevent the recurrence of the disease. After that, we do a advancement flap from the lower lid. Here, we found we did Cutler beard for the last 10 years. Now, this is the first time we detect the separation of the anterior posterior lamella is somewhat different. It is much easier. Easier because previously we expand the tissue, lots of fluid goes inside the tissue. That is why the anterior or posterior lamella separate is much more easier. This lamellar reconstruction is very important. We modified this operation as an anterior lamellar separation and posterior lamellar separation. This is the advancement flap. This advancement flap separation easier. Advancement flap for the lower lid, advancement for and the posterior lamina of the both eyelid joined to become posterior lamina bay. Now this is a filamentous knitted polyester fabric used as a tarsal plate replacement. So this specification of this fabric is 28 millimeter length, 6 millimeter central wide with 0.6 millimeter thickness and a multiple holes. Why this multiple hole? Because this multiple hole helps in the vascularity comes from the posterior lamella to the anterior lamella to become a good hole or screw effect and skin vascularity much more increase. Here, this tarsal substitutes are pliable, inert, non-reacting. We made this multiple hole to hold effect of this material. Now, this posterior lamella, we have previously replaced the tarsal plate by a silicone plate, which is published in Indian Journal of Ophthalmology. It's one of the innovative article in 2021. Now it is a filamentous knitted polyester fabric, which is used, which is fixed to the posterior lamella bay with a 5-0 polygalactin suture, and now anterior lamella is sandwiched by this implant. Now the separation is usual. We use for 2 weeks, not for 6 to 8 weeks. Why 6 weeks? Because we already stretch the tissue. Cutler beard procedure, the principle is the stretching effect of the tissue. But some of the authors from UK, they can understand, they can do the study, but they are failed because they do early division with 2 weeks, but without stepping effect that their study is failed. They are doing on failed cases, and most of the patients have ectopion. But here we apply the expander device. Expansion may causes new tissue recruitment, and the new flap is recruited, and the square flap of the upper lid is replaced by the square flap from the lower lid. This is a stage 1 Cutler beard procedure done after 15 days after removal of the suture. This is much more applicable when the patient is one eye. Now see, after 15 days, this is a healing procedure. Why this healing procedure? The increased vascularity by the expander device. We are not, this is time we are statistically proof with expansion tissue is benefited. Though with the 3 days, the disfigurement of the face, nobody tolerate. If the patient have a malignancy, tolerate for some days. But this is a beneficiary for that patient. Now, convexity downwards incision, you made the proposed incision lid and lift up the lid and separate the eyelid from upper and lower lid. Very carefully, we have a slanting from skin to the soft tissue. You give a slanting incision, either the skin or other mucosa is covered by the ragged raw margin of the upper lid. This is a technique. Don't do directly 90-degree axis of the incision. You give a slanting. Slanting may cause cover the upper eyelid border. That may cause a smooth surface of the eyelid and helps with good care of the cornea. Otherwise, if you suturing at the eyelid margin, that may rub the cornea, that may cause this corneal exposure and destroy the epithelium. Very careful, we are working over the cornea. Very careful not to damage the cornea. That is the key of your vision. So we use in this study the double arm suture, the suture not outside the skin, not inside. Previously, we use a normal suture, the vicryl, but that may rub over the skin and you can apply a bandage contact lens. We avoid this bandage contact lens because we do double arm suture, and most important is the inferior fornix, which should be formed, otherwise they may cause ectropion. This has happened in previous study. That is why they stop. The UK scientists, they are doing it early division, but without expansion, they fail. This is the first time we applied an expander device, and we are almost success, almost 10-15% done. Now, all the cases of elliptical filamentous knitted polyester fabric applied is the tarsal preference. Dimension is 28 millimeter length, 6 millimeter central wide, multiple hole. It is flexible, pliable, inner tissue substances, expansion tissue in an elliptical manner. Preoperatively, it causes recruit extra tissue for breech flap formation. That is why the early division of second week is possible. Good healing due to increased vascularity, proved by Doppler flowmetry study, baseline and after deflation. Cutler beard procedures is a stretching effect done by balloon of the 10-14 French Felicon catheter. Doesn't require a stretching effect of the usual Cutler beard procedure. Conclusion, it is very useful, particularly the patient in the one-eye patient. Tissue acceptance is excellent. No such graft failure, infection, extrusion of the filamentous knitted polyester fabric. Overall architectural support of the lid is well maintained with excellent aesthetic appearance. Short duration, a rapid expansion of skin muscle complex shows increased vascularity, proved by Doppler flowmetry study. It causes extra tissue recruitment. Again, I say, helps in early division of breech flap and good healing. Thank you for your kind attention. If any question, you can ask me. Anybody, any question, you can ask me. Our presenter can ready to answer. If any, that means you are all understand. Whether all is quite means you are everything understand. Expander is a catheter balloon. Catheter. Actually, it is a urinary catheter used in urology. So, Foley's is a silicone catheter. Foley's are two types. One is a latex and is a silicone. With long-standing catheterization, if you do, that is a silicone catheter. And short duration latex. But mind that the catheter property were used in different way. Catheter has got a balloon. You expand the balloon. That balloon used as an expander device. This is not that catheter used as a urination here. You understand? That is why everybody asking, why use a catheter? Yes, the balloon catheter is not used. It's the balloon of the catheter which is used as an expander device. Because we are in India, it's a poor country. So expander devices are very costly and it's not available in all the places of India as all the countries. Suppose Nigeria. Huh? Okay. Every your innovation is you looks like a poor patient who can afford and also see the surgeon who can perform this surgery in every setting, doesn't require too much high medical college, hospital, super specialty hospital, doesn't require. If you know the property, you can do this surgery in a simple hospital also. That is why this is the innovation of that material here. Thank you. না এখানে নয়